And it gives me great pleasure to introduce our next speaker, who's Dr Tonse Raju, who trained as a neonatologist and rose to become the Professor of Pediatrics at the University of Illinois in Chicago, a post he held until 2002. And since then, Tonse has been the Program Director in the Perinatology branch of the National Institutes of Health in the United States.
Good morning, and thanks to David for organizing this one of the very unusual topics for a conference. And I learned that he has done just about everything, carrying the box, setting up everything. It's an amazing job that he has done, and I'm really honored and privileged to come and speak to you today, especially when I see that many of the speakers here have done work in this basic aspects of cord clamping, both clinical and other aspects of cord clamping or transitional circulation. So I'm really pleased. And I bring greetings from the National Institutes of Health, as was mentioned. And this is a beautiful campus of the, please visit whenever you can. The security may be a little tight, but you will be able to make it. This is the largest funding body in the world for research, extramural research. And we spend about 80% of the $32 billion goes out to researchers around the world, not just the United States. It's a lot of money. And really, I'm very proud to be able to represent officially for the National Institutes of Health. And this is my institute, Child Health Institute, within the National Institutes of Health. And very few people know that National Library of Medicine is part of National Institutes of Health. And whenever you go to PubMed, that is in the National Library of Medicine. So I thought I should mention that because PubMed is used universally, and really people don't realize it is a part of NIH. And I'm coming to a country where the fetal physiology, foundations of fetal physiology was actually started. This was Professor Joseph Barcraft. Even today, what Barcraft and his students, and one of them was Jeffrey Dawes, that was just mentioned by David earlier, was his student. And even today, if you read this particular book and his work, many of the foundations that we take it for granted were established by his work and his students who followed up. And I am fortunate to have one of the rare books that collects all his publications and written by him. And in his honor, in California, a mountaintop has been named Mount Barcraft. The high altitude physiology lab is there, and it's named as Barcraft Lab. And the thing is, Dr. Barcraft never visited the United States. That is another, real honor to be bestowed. I think, to my knowledge, he's the only physiologist whose name is assigned to a mountaintop. All right, so my task today would be to talk about cardiac output and cerebral circulation. And I want to warn you, many of the things that we mentioned will be repeated by other speakers too, and because we all read the same papers that is available on PubMed, so you've got to accept that to some extent. So I have three questions to ask in the next 20-30 minutes or so. One is to review quickly the methods that we use to study the cardiac output and cerebral hemodynamics, and what sort of changes occur in the transitional circulation in term and preterm, and I'll keep it brief, only to cardiac and hemodynamics, and finally cord clamping times and their effect on cerebral circulation. So very simple task. So when all goes well then, the baby comes out, and infant cries on the obstetrician's hands. Someone shouts, "Time out front," and you note it down. Cord is tied, and the baby is handed to the pediatric team, and basic resuscitation is done, the baby is wiped, the nurse shows the baby off to everyone, and dad takes a picture. So, when all these things are happening, there are certain things that are happening physiologically inside the body of the baby. So the baby cries, functional residual capacity of the lungs increases, peripheral vascular resistance drops, as David mentioned earlier, and right output to the lungs, the cord is clamped, right output to the lungs preferentially or nicely begin to saturate, flow into the lungs, and oxygenated blood begins to come. A lot of it comes back, and then because of more blood is coming now, left atrium, foramen ovale is closed preferentially, so the whole transitional circulation takes place for several heartbeats, maybe several minutes, and so on. So increasing left ventricular filling increases left ventricular output. So lung perfusion continues to increase, etc. And then the cord has been tied already. Everything looks nice and quiet from the outside. And this is a tremendous amount of changes are taking place inside. So the big concern is still there. One of the concerns is, well, is it safe to delay the cord clamping in an infant who is not breathing? Because isn't oxygenation more important? Should I not intubate the baby first, get him, him or her better chance of surviving? And to answer that, I think there's a definitive study, once again from our Australian colleagues on in lambs, and the senior author is Stu Hooper, and he was very kind enough to send me his slides, and he should have been here today, but thank God he couldn't make it, so I am invited. So, but he was kind enough to send this paper. And I think this is a great paper to have for a journal club in your institute. It came in Journal of Physiology just last month. So preterm lambs were prenatally operated at 123 days of age, which is 84% of the term. And catheters were placed into the pulmonary artery, carotid artery, and Doppler probes around these vessels. And the lambs were delivered 3 days later. So all the catheters are in place, and now you just deal with the lambs, and you can monitor them and manipulate and study them. There were two groups. In one group, this is very nice, and I will go a minute slower. I mean, I'm okay in terms of time, I think. Yeah. This is my last set of major studies that I'm going to spend some time on, because that's very important for us to understand this study. They duplicated exactly what happens in the clinical scenario. That means in one group of lambs, they clamped the cord first, but did not let the animal breathe for about 2 to 3 minutes. That means similar to the case of premature baby that I showed, that for 3 minutes, there is no ventilation taking place, but cord has been already clamped. And then they measured cardiac output, left ventricle, and changes, heart rate, on all sorts of things. And the other group, they did the other way around, as now being new recommendations. They began to ventilate the animal, and then after 2 minutes, they clamped the cord. Okay, that's very neat design. And I'm just going to focus on heart rate. I'm going to skip. Next speaker is going to cover that. Left ventricular output, carotid artery pressure. Only these I'm going to present to you. The slide here again, I'll go through. Now, that is when you clamp the cord. This is the animals in the clamped first group. That means the current status, current practice in this country and many other places in the world. The baby comes out, and this is the time the baby is out, and cord is clamped here. And now they are measuring the heart rate. Look at what happened by 1/22nd. Heart rate is profoundly low. And right ventricular output going down here. And then they start to ventilate this animal. And then heart rate goes up, and then right ventricular output is going up. This is the animal clamp first group. Again, a clamp first group, what's happening in the carotid artery. As soon as the cord is clamped, carotid artery flow is going down, and the pressure is going down, and flow is going down here. And when you start ventilating, things get better. All right? So this is, so dramatic changes, and very, very clearly said it. Now they are comparing both groups together. That is, vent first and clamp first. So now this can be confusing. That's why I redrew the way that they did. Now, in the group 1, that is cord clamping first, this time represents when they clamp the cord. In the vent first group, this same time represents when the ventilation began. Okay? Look at this is why open circles are vent group. Vent first, no change in heart rate, no change in right ventricular output, and even after cord is clamped. So this, for this group, that is second group of vent first, this time represents when they clamp the cord. And for this group, this time represents when the vent began. Okay? So cord clamp and vent began and cord clamp. So I mean, in the published paper, to understand that, it gets very confusing. That's why I redrew this one with the labels here. So when you do that, you understand the heart rate has gone down here and not here. Closed circles are cord clamped first, and right ventricular output remains stable, whereas that goes down here. And the same sort of idea in carotid artery pressure and flow. So no change in the white circles, and here it's going down. And this one is profound. Drop in carotid artery flow and takes off afterwards. So the bottom line is, there is no doubt at all that if the baby is not ventilating, cord clamping early is dangerous. I mean, if any, those are the babies who get benefited by keeping the cord open for a longer time. So, summary of my human studies then, a small number of studies, they showed delayed cord clamping in preterm infants has reduced postnatal drop in blood pressure, improves left ventricular output, improves brain tissue oxygenation. However, some logistical issues, how to, still remain to be answered. I said animal studies, good result to handle the preload, whereas diminished capacity to handle the afterload, and antenatal steroids seem to help. Cord clamping before the onset of ventilation leads to a profound drop in heart rate. And almost all animals, amongst all animals, Homo sapiens has the longest cord. And apparently, I didn't know this until recently, at term we have 20 to 22 inches of cord, adjusting for the total body weight. Why do primates have longer cords compared to other animals? This is an explanation given. Human cord is long in order to allow the mother to pick up her helpless newborn child, carry it away from danger without exerting harmful traction of the placenta. The cord is more than 18 inches, they will allow the child to be put to the breast. That helps reflex stimulation and help the delivery of the placenta. That's very nicely said. And just another 30 seconds I will show you something very interesting from my institute. So my institute, Child Health Institute, the very first, it could not have happened without the help of John F. Kennedy and his sister, Eunice Kennedy Shriver. And it is named after Eunice Kennedy Shriver now. The first director of our institute was Robert Aldrich. And when he was, someone said that Aldrich was a professor. You may know Prescott-Aldrich syndrome. That's that Aldrich, very famous. So NIH director called him to take over the new position, and he said, no, I don't want it. And a few days later, President Kennedy, who has been just elected just recently, he called him to take this job, and Aldrich again declined, but ever so politely. President Kennedy hung up, and Aldrich felt relieved. But then a few minutes later, a telephone rang. This time it was the president of the university. He was very angry that Aldrich had declined the president's offer of highly regarded position, which might harm the university's reputation. You are fired, shouted the president. and Dr. Aldrich was the chairman of the pediatrics, and he was now fired. And Aldrich was recovering from shock and disbelief when the telephone rang again. The voice on the other end was familiar. Hi, this is President Kennedy. I understand you don't have a job. I have something in mind you might be interested in. Aldrich moved to Bethesda in 1963 as the first director of NICHD. The rest is history. Thank you.